Okay. So we're going to record today. I'm going to turn off this transcription because it's very annoying. How do I do that? Stop transcription. There we go. So we're recording today. This fact finding we'll see if it's a model fact finding or not, depending on how things go. But I wanted to kind of show how one approach for doing a fact finding. I know at least a few of you are going for boards very soon this week. Hopefully, observing someone else will give you a bit of a sense of Schadenfreude. For those of you who don't know, it's a German word. It means taking delight in the misfortune of others, or at least maybe picking up some tips. But we'll stick around at the end and talk through a little bit about kind of why I did what I did, why Callie did what she did, if there's anything that I missed and, grotesquely screwed up, and all that good stuff. So, but we're going to kind of run the process through like we would, and we'll go from there. I have paper and pen. I am virtual, but it's got honor that I'm not cheating. So, all righty. So unless anyone has any burning questions or anything right away, let's get rolling.
Okay. Would you like to take a few minutes to make an outline?
Yes, please.
Let me know when you're ready.
Okay, I think I'm ready.
All right, I have two cases you can choose from. One is a 10-year-old girl with behavioral issues or a 37-year-old man with cognitive changes.
I'll take the 37-year-old man, please.
What would you like to know?
All right. Can I get additional demographics, please?
37-year-old, Caucasian, left-handed, assigned male at birth, identifies as a man, and presents as a man.
All right. Primary language?
English.
Does he speak any other languages?
He previously knew Arabic and Spanish, but no longer feels fluent.
Okay, fair enough. And who referred him, please?
He was referred by his epileptologist.
Okay. Was there a referral question?
Assess current cognitive status following long-term monitoring unit stay and adjustment of medications.
Okay. Okay, and what complaints does this gentleman have?
So he has complaints of some memory difficulty. He says it's kind of harder for him to learn new vocabulary in his other languages that he's trying to learn, has to repeat himself. Also having some kind of inconsistent attention difficulties that he describes as his mind wandering, some word finding difficulties on a daily basis. When he was asked about personality changes, he described himself as being kinder. He did report that prior to his long-term monitoring stay, he was having some staring spells and increased memory and attention difficulties, but since the medication change, he reports that he's at his typical baseline.
All right. Any physical or emotional complaints?
None that he spontaneously provided.
Any that he non-spontaneously provided?
So he says that he's been having some anxiety, kind of anxiety depression, but that he doesn't really view it as interfering in his functioning. He occasionally might stumble, but there's been no falls.
Okay.
Can you be more specific about what physically you're looking for here?
Just kind of any general, falls or any motor, lasting motor changes, sensory changes, neuropathy, anything like that.
Okay, so he's got total loss of hearing in his left ear and 30% hearing in his right. Vision is normal. Some trouble falling and staying asleep for a couple of decades. Reports feeling generally rested with adequate energy throughout the day, even though the sleep isn't quite as good as he would like.
Okay. And any collateral?
Yes, we have the report of his mom, who says that she's noticed mild, consistent forgetfulness, sometimes maybe disoriented in new places, like getting turned around when taking public transportation to a new place. And she has some concern about his money management because he seems to be giving money to people who ask him for money.
Oh, well, that could be problematic. Okay. Thank you. Okay. Any prior neuropsych testing or evaluation done?
Not like, no.
Okay. Any like just cognitive testing, screeners, anything like that? No. Okay. No problem. And functional history sounds like he's independent, but his mom has some questions about his money management. Is he driving?
He does not drive because of his seizure risk, but he does coordinate his own transportation independently.
Alrighty, thank you very much. I will wait to circle back until we're done with this section here. Can you give me his medical history, please?
So some of the records are not available currently, but he does have a history of epilepsy, hypothyroidism, and depression in his chart.
Okay. Can you tell me a little bit more about the epilepsy? I'd be curious to know the course, onset of the seizures, the types of seizures he's having, whether they're general, partial, generalized, whatever, and then any treatments that have been done in the past too.
Okay. So treatments have been medications. Typical episodes look like staring spells.
Okay.
Where he's not responsive during those staring spells.
Okay.
What would you call that?
An absence seizure. The old term was petit mal, but I believe the current nomenclature is absence, which is a generalized seizure but without tonic-clonic symptoms.
Okay.
How long has he had those staring spells?
For about 18 years or so, but they've been well controlled, but kind of peaked back up about a year ago and have subsided now that his medication dosage has been reduced.
Okay. And I know that absence seizures can often start in childhood, and frequently get misdiagnosed as ADHD. Does he have a diagnosis of ADHD?
He does not.
All right. And so no any treatment other than AEDs at this point?
No.
Okay. And what AEDs is he on now?
He is currently on Devalproex and gabapentin.
You have dosages?
2250 a day for the Depakote. Gabapentin is 800 milligrams 3 times a day.
Okay. I think max is 3,000 for that, so that's a relatively high dose. Thank you. Any other seizure semiology description, any aura, any postictal confusion, drowsiness, depression, anything like that?
So he does have this history of kind of depression, anxiety, long-standing, doesn't feel like it's interfering with his functioning.
Okay. But no aura.
No.
All right. And how frequent are his seizures currently?
So they've been really well controlled for several years prior to their kind of reemergence, and then now not occurring for the past couple of months before I saw him.
And over how long a period were they reoccurring?
Maybe a couple of months that he had
Okay.
sort of had them infrequently.
And how many do you know about the frequency?
Probably over his lifetime, maybe about 10 events.
That's it. Okay. And any weird transient sensory abnormalities that could be construed as like a simple partial seizure?
No.
Okay. 10 events total is not a lot, unless he has a history of status epilepticus, which I'm not hearing that he does, correct? Okay.
Correct.
Oftentimes that would not necessarily be enough to lead to some cognitive dysfunction, but we will see. Okay. And you gave his other medical history as hypothyroidism, some depression, but that you didn't have it all. Other than the 2 AEDs, any medications that he's on?
Yes, he's on citalopram and levothyroxine.
Pretty standard. And as far as other studies that were done, we talked about the prior neuropsych. Is there any neuroimaging?
There is talk of that in the record, but it's not available currently.
I hate when that happens.
Lab work was all within normal limits.
Okay, that was my next question. Do you have results of that long-term monitoring?
So they were able to capture his typical episodes, and it was so it was related to having too high a dosage of Depakote. There was no EEG changes during that long-term monitoring, so they reduced the dosage, and those what looked like his staring spells have no longer recurred.
Okay. So there's no we don't know exactly what the electrographic profile was because that wasn't recorded.
Correct.
Okay. Something I want to follow up on that you mentioned is he has total loss of hearing in his left and 30% reduction in his right. Do we know why that is?
I do. Do you know? What are your thoughts about why that might be?
Well, it's curious. Does he have a history of cancer at all that we know of?
No.
Okay. I don't know about the and sorry, before we get back there, any other AEDs he's been trialed on in the past that he's no longer on?
Yes, but I don't have that information.
Other medications that he's been on for a prolonged period that he's no longer on?
No.
Okay.
Are there medicines that you know of that could cause hearing loss?
Yeah, the reason I asked about his cancer history, some of the platinum-containing compounds, so cisplatin most notoriously, but also carboplatin and some of the others, can cause, I think the term is ototoxicity. And you can see those kind of generally used, and someone his age, you could think of like a seminoma, testicular cancer is a common usage, but they're used for a lot of different cancers. And they can also cause some cognitive problems too. But doesn't sound like he has a cancer history, and we don't know about that. So,
Correct.
any history of TBI or infection, other hospitalizations?
So those records are still out.
Okay. It's unfortunate, but it does happen. All right. Let's go to social history.
He lives alone in an apartment. He's never been married, has no children, but has had several long-term relationships in the past. He was raised in Texas by both of his parents, has 3 siblings. Anything else specific you want to know about him?
Educational history. How far
It's
did
a
you get in school?
high school graduate.
Okay. And any problems, failed repeated grades, or any academic difficulties?
No, he did really well in school.
Okay. And no developmental abnormalities, birth abnormalities?
Correct.
Okay.
Correct. He served in the Army straight out of high school as an interpreter and interrogator.
Oh. Right. Any deployments?
No.
Okay. Any known exposure to hazardous substances while during his military service?
Not that he knows of.
Yeah. And is he working? I think you mentioned something about employment.
He is on Social Security disability and he's 60% service connected.
Okay. What's he service connected for? Do you know?
I do not have those records.
That's okay. All right. Lives alone. All right. All right. And not currently working. All right. I think just for a second. And we don't know about prior surgical history. Is that correct?
Correct.
Okay. All right. So let me sum up what I know. We have sorry. Any neurologic records or other medical records that are available? That would be pertinent.
None that are available currently.
Most unfortunate, but it happens. All right. So we've got a 37-year-old left-handed white male. Primary language is English. He was raised in Texas, but has spoken a couple other languages in the past. Just got off of long-term monitoring and a medication adjustment. He's now on a relatively high dose of valproate gabapentin. He has a history of epilepsy. It sounds like episodic seizures for about 18 years, but with only about 10 total events over that time. Seizures had been well controlled, but then recently were less well controlled and had a medication adjustment and now are better controlled. He's reporting some attention and memory problems as well as some word finding difficulties. Reporting that he's kinder, but it sounds like there may be some concerns about naivety or things. He's giving money away and his family's concerned about that. Reporting some subclinical mood symptoms, long-standing poor sleep. One curious symptom that I haven't quite figured out kind of where to place is this hearing loss, full hearing loss in the left, 30% in the right. His work as an interpreter in the Army wouldn't seem to fit with that if he had been in EOD or something with explosives, maybe so, but not quite sure about that yet, but hoping to figure that out as we go. Besides the epilepsy, has hypothyroidism, depression, and I think that is about it here. EEG was not terribly helpful, but they did capture an episode. Do you know what AEDs he was on prior to this recent adjustment?
It was the same AEDs, they just lowered the dose of Depakote.
Got it. Okay. Okay. All right. So And I asked about any cancer history with that may help explain the hearing loss. So right now, the most obvious as far as kind of initial differentials that I can come up with is, I mean, he has epilepsy, he has a seizure history that could certainly be affecting cognition. I mentioned that it would be a little atypical for only 10 events over the course of his life to cause some major cognitive dysfunction. But sorry, writing here. The medications that he's on can also cause some cognitive side effects potentially, and the fact that he's on polytherapy, there's a synergistic effect, and you see more cognitive side effects from seizure medications when there's multiple. That would be kind of the biggest thing that stands out to me. I have my acronym here and kind of going through other possible differentials. It's possible there's some sort of vascular malformation or something that may have led to the seizures, although I would think that would be more likely to cause something like a simple partial or a complex partial with secondary generalization than the generalized absence type seizures that he has. Possible history of infection that could have led to that as well. But his age of onset is relatively consistent with what we'd expect for someone with absence seizures. There's no history of TBI, you said, so I'm ruling that out. Not hearing any history of autoimmune disease, not on any medications I would expect for autoimmune disease. I had mentioned cancer history. You said he does not have a cancer history, correct? So I'm ruling that out. That would, if he had some sort of tumor, either the tumor itself or the resection, there's a whole host of different types that could, and some are more likely to cause seizures than others. Again, I would not necessarily expect the absence type seizures that we're seeing, but it's possible. Idiopathic absence seizures are always a possibility. I'm not hearing anything that would point strongly to anything congenital. That's not my area of strength, but I would think about something with birth defects or delayed developmental milestones, and it sounds like everything was hit on time. So that is much, much lower on my list. So at the top of my list right now, it would just be a simple idiopathic absence epilepsy. But I'm considering that there could be a vascular malformation, maybe a history of infection or some other irritant or triggering cause, possibly. All right. Anything else that I went too fast over that you'd like me to know?
I don't think you asked about the course of his cognitive changes, did you?
I meant to in terms of the system history. Yes, if you wouldn't mind giving me a little bit, that would be very helpful.
Okay.
Thank you.
So it's been going on for about 19 years.
Okay.
It was acute, a period of recovery, stability, a little bit of dipping over this past year, and now back to stability. Does that change any of your differentials there?
It does, actually. Yeah, so it sounds like that is slightly longer than his seizure history, which is about 18 years, although around the same time. So that makes me more suspicious that something happened to him 19 years ago. So he would have been, my math isn't working, 18 or so. Either, you said no history of TBI, so I would think something either infectious or discovery of a vascular malformation, or something like that. Yeah, some sort of provoked epilepsy would be a higher amount.
Okay.
And if that is the case, I would expect that the cognitive data should show some focal deficits, but we shall see.
Okay. Are you ready for the data?
Yeah, can I start with behavioral observations, please?
Yes, just a moment. Let me see if I can share my screen here.
Ooh.
All right, what are you seeing?
I see a very fancy logo, SCN
Thank
logo,
you.
and it says results.
Okay, excellent. Let me see if I can do this. Oh, okay, I think. All right, let me. I should have tested this out.
I've been in your shoes. I know that's.
If we were in person, I would just hand it over the table to you.
I'm not sure if it works to share things in Teams, but in a pinch, you could email it to me, and I provide my
Yeah,
Scout's
I
honor, but
might
I'll do it one at a time.
I might put it into the chat. All right, so you asked for behavioral ops.
Yes, please. Oh, right. All right, so for the sake of time, I'm going to just kind of look here and point out things that seem abnormal. He wears a right hearing aid, complete loss of hearing in his left. We know that, but it didn't seem to affect testing. No notable mood or motor abnormalities. He wasn't psychotic or anything. That's good. Speech was relatively normal. Somewhat. So a little bit deferential or conscientious, which could speak to executive functioning as a strength, perhaps. We'll see. But other than the hearing loss, which we knew about, the behavioral labs seem relatively benign. Nothing that sticks out there. Thank you. All right. Now, I always forget to ask about something, but let's see how we go. So validity data, please. Okay, so looking at the standalone and embedded validity indices, I'm not seeing anything. What is the cutoff on the SIMs? I'm less familiar with that.
I don't quite remember, except that's normal. I think it's
okay.
23. I think
Oh,
23
okay.
and
Wow.
above.
So barring that, which I'm less familiar with, I'm not seeing any evidence that would suggest there's frank performance validity issues. Thank you. Okay, premorbid testing. All right. So we've got and that's that's just the FSIQ with Tower 108, which would be, now I'm trying to remember, but that probably is about the 63rd, 64th percentile, which is relatively, actually, that's spot on with his WACE-4 vocabulary scores. 11 skill score would be that. So we're looking at someone who's on the higher but generally average sort of side of things. So, okay. And that's consistent with reported educational history and all that. All right, thank you. Any IQ or general cognitive testing?
So this is something you had asked about before that I hadn't given to you at that point, but.
Oh, okay. We had an MMSC of 27 out of 30. Didn't know the county or the floor and got one off in serial 7. Okay, that's 27 out of 30 as a score is a little low for what I'd expect, but not knowing the county or what floor of the building is not the end of the world. Any IQ testing?
No.
Okay. Any academic testing?
No.
Okay. Any neurobehavioral testing?
No.
How about motor, sensory motor?
None.
Really? All right. Okay, how about attention, please? All right. The digit vigilance, so kind of working backwards here. Digit span was 25th percentile. That's about where we'd expect, maybe a little low, but it looks like he did the best on sequencing. So his basic attention with digits 4 is a little bit on the low side. Digit vigilance test, which is a measure of sustained attention, 45T is going to be about the 32nd percentile, which is not abnormal compared to where he was at premorbidly. 2 errors, again, 57T, that's about right. Trails A was exceptionally strong. Wow, 70T. His coding and symbol search were similarly within normal limits. Does that say PSI is 110 or 10? 10, oh,
It's
105.
105. 105.
Okay. Which would make some sense. So his basic attention is a little on the low side, but processing speed, more complex attention, working memory, all that seems okay. I had mentioned the medication effects. We could be seeing that here potentially, but we'll see kind of what the rest of it brings. All right, so we got processing speed. How about language abilities, please? Thank you. All right, so his Boston is just a little on the low side. If we're using about a 1.5 standard deviation reference, that's going to be just a little lower than we'd like to see. Now, a Boston naming test and a 37-year-old, there's some items on there that he may be less familiar with, and abacus and such, but still, this is a measure that's been well used in epilepsy populations. It could point to something possibly left temporal, but we shall see here. NAB naming, which is better for someone his age, 31T, so even lower. So that is suggesting there's possibly something left temporal. But I will circle back to all that at the end here. His Watar word reading was fine. His crystallized verbal abilities were fine. Animal naming was fine. And is FAS on there? Did I just miss it?
I include FAS in a different domain.
All right. So as far as language goes, confrontation naming is the only abnormality I'm seeing. Thank you. How about visual spatial functioning?
Sorry about the formatting.
It's okay. His mother had mentioned that he gets lost in new places. This was something I didn't say earlier, but I think is worth pointing out that, that could be indicative of a visual spatial problem. However, all right. So it looks like his block design score, I'd still consider that within normal limits for him. It's on the lower side. Do you know if he did better without the time component? Or why that score is what it was?
Yes, so he timed out on the last two he timed out on items 11 and 12, which are the first two after the 9 blocks come
Yep.
in. He stated that he felt overwhelmed by the complexity.
Okay. It looks like there's some mild visual constructional issues on the pentagons, but he self-corrected. One thing I forgot to ask, and apologies, going back to the attention or the language domain. Anything more you can tell me about his confrontation naming, his Boston and NAB naming as to why things were low?
So he said muffle for muzzle. He said duck for pelican. He stated that he likely never knew the last 5 words that were administered to him. He got 5 out of 11 correct with phonemic cues. On the nab, he said pear for lime, hanger for clothespin, cooking spoon for the ladle, horseshoe for magnet.
Interesting. Okay, so it sounds like there's some evidence of both, mainly phonemic, but both phonemic and semantic paraphasias there, as well as possibly just some dysnomia with not knowing the last 5 items. Okay, thank you. All right, we've got visual spatial done. Let me see memory, please. Okay. Okay, so I'll do verbal memory first. Formatting makes it interesting here, but let me do what I can.
Okay.
So overall, his learning abilities looked fine. His short delay free recall was what's the most words that he was able to provide correctly?
So the most he got was 12.
Okay. So if we're using that as kind of a high point, and what was his trial 1 score?
7. So it went 7, 8, 10, 12, 12.
Cool, thank you. So his short delay of 8, so that's 8 out of 12, and as we can see, 16th percentile, not frankly impaired, but lower than I would like to see. Did just 1 point better with Q, which, yeah, that's about what you'd expect. What was his list B score?
I do not have that information.
Okay, no problem. Long delay free recall was a little bit lower yet, 7 out of 12. That's pushing us to the 7th percentile, which is going to be probably an impairment for him. Interestingly, did worse on cued, which that could just be a quirk of human behavior, but was there anything notable there?
He had a lot of intrusions.
Okay. How many intrusion errors did he have on the CVLT?
I don't have that information.
Okay, but 13 false positives, which is a lot, and 12 hits. So I'll do WIMS here, and then I'll kind of come back. WIMS was fine. So he did better when that structure was placed for him. Looking at visual memory, wow, marked difference. So he's total score of 11, which is far less than the 1st percentile. Delayed recall was similarly quite low, but his recognition was, well, hits were okay, but again, quite a few false positives. So to kind of sum up memory, verbal memory seems to be relatively okay, certainly stronger than visual. I am seeing that he has, we're going to say, and let me ask a clarifying question. His false positive errors, were they related words, unrelated words? What kind of errors were they?
On the CVLT, all of his false positives were from trial B, list B.
Okay. So you can see that with executive dysfunction sometimes. It would be tempting to say that this individual has a verbal memory consolidation deficit, but the WIMS would argue against that, as would that pattern. That sounds more like a discriminability thing to me. So you could see that with more anterior dysfunction. That sort of pattern would be less consistent with frank medial temporal dysfunction. However, looking at the BVMT, they're much poorer scores, poor discriminability. This is a definite weakness for him and could indicate some medial temporal dysfunction. hemispheric dominance, we'll come back to that, but that could play a role here. But certainly verbal memory is stronger than visual. Thank you. How about executive functioning? All right, thank you. So FAS, to round up that language for fluency is fine. Things that are a bit more crystallized, like similarities, somewhat argumentative reasoning, are all fine. And yeah, I'd say executive functioning across the board, he's looking okay. And mood or psychological testing. Thank you. Okay. So, and forgive me, a PHQ-9 of 6, I believe, is borderline, but still negative. Is that correct?
It would be considered mild.
Okay. PCL of 23 is negative. So, some mild depression. I don't know the life satisfaction questionnaires. Can you describe those for me, please?
Yes, so greater than 15 would be, let's see. So he would be considered in the satisfied range. Greater than 31 would be extremely satisfied. Greater than 21 would be slightly satisfied.
Okay, thank
So
you.
he would be considered satisfied with his life.
Okay. What time did we start?
And then Quoley, are you familiar with that?
Yeah. I think I have about 10 minutes or so. Want to double check.
Sorry, can you repeat that again? My
How much time do I have left? I think I have about 10 minutes.
Yeah, we started at about 3:05, so yeah.
9 minutes now. Okay, I'll talk fast. All right, so in this gentleman, I described his history previously. Looking at test scores and putting it all together, I'm seeing, let me just put this down here. Any other test domains that I forgot to ask about? I think I got them all.
We do have a family report. She completed the Zaret caregiver burden and reported little burden.
Okay, thank you.
And we do have an MMPI, but I won't make you interpret that on the fly. We'll save that for another day.
Fair. Okay. Okay. So this gentleman, his neuropsych profile appears to show some deficits in basic attention, confrontation naming, visual memory generally, also some verbal discriminability, and some mild depression as well. So kind of thinking about that neuroanatomically, in with a brain that's normally organized, or more typically organized, I should say, this would appear to be a bit conflicting. We've got some evidence of some language problems. We've got visual memory being a pretty notable weakness and some visual constructional problems, which suggests some bilateral, potentially bilateral involvement. What I think is interesting in this gentleman's case, though, is the fact that he's left-handed. There's about a 15% chance that, that language is on the right, which is possible. So, or that they're flipped. So I think it's very possible that we are looking at And I really wish we had some motor testing, but since we don't, it appears to be
So what would you be looking for in the motor testing? What would you
Well,
hope to see?
So with, let's say with like temporal problems, which it appears we may have, the visual memory is less helpful often than verbal memory, because you can see visual memory problems in left hemisphere dysfunction for someone who has typical organization, because a lot of those things are verbally mediated. So it can be a little tricky to determine dominance, but motor testing being hardwired, except for people who have seizures at a very, very early age, that's going to be relatively pathognomonic for which hemisphere has greater dysfunction. So that can help localize what side. In his case, I would be more suspicious for right hemisphere dysfunction, despite the language, the naming problems, and would suggest that maybe his language is on the left or on the right, excuse me. I think that fits a little bit better with kind of the preponderance of data. It's less likely that his visual memory would be on the left, and also visual spatial abilities. So I'm thinking there is a possibility of greater right hemisphere dysfunction, with the possibility that his brain is normally organized and there's just kind of general dysfunction, which is kind of a secondary possibility. I'm not entirely sure. As far as etiology goes, kind of going back to my initial, and let me refine what I said, excuse me. So as far as hemispheric involvement or more cortical involvement, I am seeing some evidence of mesial temporal dysfunction on the right, general kind of frontal temporal dysfunction, which appears to be worse on the right, with those mild visual constructional impairments we saw with his pentagons and such. If the brain is atypically organized, like I hypothesized, there could be some that would fit. If his brain is normally organized, then we might expect some left temporal involvement as well. But generally frontal temporal dysfunction, I'd say right greater than left. The depression doesn't surprise me. I'm surprised it's that mild. It's common in most serious medical illnesses, but epilepsy can be often worse. All right, I'm looking at the time. I have 4 minutes. So as far as etiology goes, I kind of stand by what I said about possible provoked seizures. Given the absence seizures, I suspect, and the course of his cognitive symptoms, that there was a major dip. Things improved, kind of seemed stable, and then got worse again. I would guess that there was either some sort of infection, meningoencephalitis or something like that, or maybe a vascular malformation that was discovered. There's no known neurosurgical history, so that would make the infectious etiology more likely in my case. And whatever it was led to the development of a seizure disorder, which were well controlled. The fact that his cognition has been worse in the last year doesn't cleanly fit with this recurrence of the seizures, which could suggest another bout or recurrence of the infection, or what might be more plausible, if there was some sort of vascular malformation that it was again causing issues. You know, maybe he had some symptomatic treatment, but it's kind of flared up again. Neoplastic would be on the table. You said there's no cancer history, so I'm ruling it out, but that would not surprise me. That would, if there was a not particularly malignant lower grade tumor, or a tumor that was benign that was growing, that could certainly give you this course.
Okay. How about recommendations for him?
Recommendations. Okay, so it seems like his seizures are relatively well controlled, and cognition has returned back to baseline, which is good. This is a young man. I think it's important, first off, thinking about his medical needs, that, you know, to take his medications as prescribed and all that. And I think his mother had some concerns. Oh, that was about his money. So, you know, I think living alone, I don't have any major concerns for that. It seems like he's taking his meds as prescribed. As far as his money management and being more generous, it's hard to kind of ferret out exactly what's causing that. If that's some subtle executive dysfunction that didn't get picked up on the testing. If that's cultural, he's from Texas, but depending on his culture of origin, that could be some sort of cultural value. But I think he's still capable of managing things independently, but I would want his mother to kind of keep an eye on things a little bit. Seeing some mild depression, nothing too severe, but given that he's dealing with a pretty significant illness, I think, and he is on citalopram, but the research suggests that co-occurring psychotherapy can be helpful. So I think doing some brief course of CBT can be helpful for him. His verbal memory certainly suggests that that could be doable, although I would suggest he kind of keeps things written down so he doesn't make mistakes. Driving, that's not less on us. I don't have any major concerns about him driving from a cognitive perspective if you're able to use a GPS. Otherwise, he's likely to get lost because of that visual memory. But I know most states and jurisdictions, he's not going to be cleared for a year or so because of the seizures. He is young, like I said. He does have some cognitive impairments, but to think this is someone who's going to be an SSDI for the rest of his life is a little bit hard. So if there's any sort of vocational rehab program, either through his local VA or some sort of back to work program where he can get even just some volunteer work and kind of get out in the community, I think that would be good for his mood and also just for his quality of life. And lastly, if there's any major changes in cognition to come back, but given that I'm not hearing anything about surgery being proposed or anything like that, he wouldn't necessarily need to follow up with us later. So There we go.
And I heard you talk about etiology. What about the diagnosis?
So I typically don't diagnose with DSM, but I'll try to get it here. He would meet criteria for a mild neurocognitive disorder or minor. It's mild. It's definitely so using ICD nomenclature, he would have like an R41.89, that other signs and symptoms where he'd have some cognitive dysfunction that was associated with likely with the seizures, and possibly also the medication effects. I would say probably all of that together. Okay.
So neuroimaging is in. Tell me what you're seeing and what you're not seeing.
Awesome. All right. So we've got a CT scan. What am I seeing here? Upper left, there's some sort of hyperintensity. Could be an artifact, could be something surgical, but I'm definitely seeing a right, let's say, frontal temporal lesion of some sort. Possible, you said no neurosurgical history, so less likely to be a resection, but either like an abscess or some sort of stroke or other prior lesion, maybe from that vascular malformation I mentioned.
So that would be his eyeball, his eyelid.
Oh.
So that's a metal artifact from his eyelid.
What?
So let's ignore that.
That's a piercing or something. Okay. So, if we're flipping things around, there's definitely evidence of some right frontal temporal lesion, probably some encephalomalacia there. And that would be consistent with the cognitive pattern that we saw.
Anything on the left?
Some things I'm doing here is looking at left versus right for comparison, for any changes in midline, any gray-white differentiations, all that kind of stuff. It's hard to tell. There could be something on the left, a smaller area of maybe encephalomalacia, but it's hard to tell if that's just the cut. And we're getting, I'm looking here at the bottom right, and we're getting just some sulci, but I think there may be something a little bit smaller there. That's going to be posterior frontal areas, which I'm surprised it didn't affect his expressive language a bit more, but yes, something on the left as well.
Okay, good. I think that would be the end of the examination.
Okay.
How did you feel?
More nervous than I expected and a little bit more disorganized than I expected.
Yeah, it's one of those things that just practice makes better, right? Like
Yeah.
the more folks can prepare for that, it's like the one part of the evaluation you can prepare yourself for, I feel like, more than some of the others.
There's a lot of moving parts in this case. I'm thinking about, I didn't do as good of a job, focusing on the negatives, of saying exactly what was causing the cognitive dysfunction. I talked about etiology, but I could have been a bit more explicit. What was going on, by the way? Can you put me out of my misery?
Bacterial meningitis.
All right.
Yeah. So yeah, I think you could have asked about the course of the cognitive difficulties to kind of give you a better timeline of what that might have been looking like. It is a complex case though, with a lot of things going on for him. Yeah, so bacterial meningitis. So you were spot on with the infectious etiology. I mean, you sort of had other things more in your differential, which were all also reasonable things to have in your differential. So it doesn't matter if you get exactly to the right answer, right? As long as your reasoning for how you got there makes sense to the examiner. And so the more you can externalize that, like you did, kind of walking through your differentials. I know it's not this because you said this and this and that doesn't make sense with that. But this could be there, this could be there, this could be there, because they may or may not give you the records that you would need in order to narrow it down further. So you always had infectious disease as part of that high on your list of differentials, which is exactly where it should have been. So you did really well there.
Would you pass me?
I would. I think you did great.
Thank you.
I think you did great. Great recommendations. You did really, really well.
Thank you.
And then, yeah, I kind of pushed you for that diagnosis, and you saying that's not part of my typical clinical process is really good information for the examiner to have. Because if it was part of your typical process and you hadn't mentioned it, that's more concerning than it needs to be, right? So kind of letting them know, it may be an infection, but I really I haven't seen a lot of cases of infection in my process, so that they can sort of make sure they're thinking about your performance within that context. I think that's really, really helpful for them. But you did a great job externalizing. You were sort of converting every score into percentiles, which in my opinion is going the extra mile. I think as long as you're able to say sort of like this is mildly impaired or like severely impaired, if you sort of have what you would classify that in your brain and able to externalize that, then that's probably as much as they're really going to look for. But you need, having that facility with all the different types of standardized scores that you could be presented with is really, really an important thing for them to be able to see. I thought you did really well with that.
Thank you. Appreciate it. So some things that I did ahead of time, I used the vitamins acronym, vitamin CDE. So that's vascular, infectious, traumatic, autoimmune, metabolic, toxic, idiopathic or iatrogenic, neoplastic, my favorite, psych with an S, or seizures, and then congenital, a degenerative condition or something endocrine. I try to go through all those and right next to them, kind of as I'm thinking about it, what could be going on, so that, it's easy to kind of get that tunnel vision and focus on one thing, and then that's the thing, and it's hard to kind of think outside the box. So that's something I try to do. I also wrote down the headings of my typical report and checked those off as I went, to make sure that I mentioned everything.
And I think with IADLs, you sort of started asking about each individual thing. I might just ask for IADLs, like just ask for that as a blanket section. And then if they push you to be more specific, they can, but I didn't give you some information because you didn't ask for it. I don't know what they would do in that exam situation.
I try to do that, and I just didn't somehow. So that's good advice. So when it came to the data, I used to write out all the things I wanted to ask for and then check them off. But what I did here was sort of visualize my score sheet and did it that way. I think there's like 11 or 12 I counted one time of things you should ask about. So I was counting and making sure I had the right number.
Yeah, you did a great job of that sort of efficient gathering of information. And they can always say, no, I don't have any of that. But the the more you ask for, the more you'll get.
In terms of putting it all together, something that I tell people is every time you say something about the data, it should take things up another level. So don't just talk about the scores. I did that a little bit. Part of that I want to say was stalling because of the format and having to kind of
yeah, that was
whatever.
not how it would be in the actual exam.
Yeah, but like, okay, fine. You don't need to talk about each score individually, but talk about functions or domains. And then when you bring it all together after that, talk about what's most impaired and if you can rule something out. So like if his executive functioning had been poor, I would have said, his verbal memory is probably due to executive dysfunction, but visual memory is a primary, area of impairment. You're kind of taking it at that level and then tying that to the neuroanatomy and then finally tying that back to your diagnosis. It's kind of the different levels, rather so you're not just kind of sitting there spinning your wheels.
Mm-hmm. Mm-hmm. Yeah, absolutely.
I tried to, and you can always do a better job. I tried to do as much as I can, kind of verbalize as we were going about why I was asking things. And you asked some really good questions, like about the cancer history. Well, why would that be important? The hearing loss with the infection makes sense. I didn't tie that together. You're not going to hit everything. That's okay. That's okay. But that was the first thing that jumped into my mind was, did he have a tumor that would have led to seizures and then recurred? And if he had treatment, that could certainly have caused hearing loss. And I was perseverating on that a little bit, both because I was perseverating on it, but also because I was thinking, if I didn't ask the question right and there was something really there, I would kick myself. So
no, yeah, it's an interesting. If you don't, you should be asking about that hearing loss. It's an unusual physical finding for this patient that's so young, and so it is important information that you should ask more about and keep in mind different etiologies that might show up with that finding.
Yeah. So I tried to verbalize as much as I could, but then at some point realized that I was talking too much and running short on time, so sped things up a bit.
Yeah, and they'll sometimes kind of prod you along a little bit of like, okay, let's move on to the next section. But you should also be mindful of the time as well as the examinee of kind of making sure you're moving yourself along efficiently as much as you can.
On my actual exam, I got to the end and he said, I think he meant to ask about like whether the neurologist sent over a report. And I said, you're right. And he sat there and I said, did the neurologist send over a report? In fact, he did. And then it was, it's like, okay. But which was helpful. So they, they're not trying to like, well, technically, like they were being helpful as much as they could. So that was appreciated. From the group, any questions, comments, thoughts, clarification? Anyone have anything from our panel of observers they want to say? Certainly someone's got something that was helpful, something you were wondering about.
Well, while they're thinking that the eyelid finding, that was because he had a cranial nerve 7 palsy, and it was a gold implant in his eyelid to help his eyelid stay shut.
Oh,
isn't that interesting?
I sort of assumed it was like a piercing or something like that.
Yeah, if it had been able to be removed, he would have been asked to remove it.
Did I forget to ask about substance use? Did that happen?
You did, yeah. And family history. I think family history was the other thing you didn't ask about.
Oh yeah, and that's on my report. I should see. Well, I'd say that I wanted to leave a couple things out for everyone, but okay, there's vitamins. It is likely, Sean, that they will show you the images.
They'll want you to talk through what you're seeing.
Yep. I got images. It was like this, clear that there was something wrong. If you can say what sort of scan it was, great. If you can if you need to stall and talk a little bit about kind of what you're looking for, that's great too. But yeah, expect that you'll actually see them.
Right. And if you can tell them, like, I rarely have the raw images available to me in my clinical work. I really trust the radiologists in my system. Like, give them the context for why you may not be super comfortable navigating around an image. But the more you can be comfortable with it, the better.
Something else I should have asked that I would encourage everyone to ask if there's seizures that I forgot about. So head injuries, yes. Fever is over 104. Or childhood infections, things like that. And then obviously a family history of seizures. Shouldn't Mike Schoenberg would be disappointed in me that I forgot to ask that. So just kind of in the milieu, something I neglected, but things that are good to kind of ask about when you have a seizure case. And it threw me a little off that you said right from the start it was coming off long-term monitoring. It's like, oh, we're just jumping there, which then I thought, well, it can't be that straightforward. So there has to be more.
Yep. So that kind of secondary epilepsy, right? It's there's a lot of injuries to the brain that can then result in epilepsy, but the epilepsy may just be a secondary thing going on that you should look for other things behind it.
And I tried to talk through, with, and I believe someone correct me if I'm wrong, I think this is right, that something like a generalized epilepsy like absence seizures would be more likely to be idiopathic or less due to like an insult. But bacterial meningitis would be less of a focal insult too. So that does that makes sense.
Right. And you talked through that really well.
Thanks.
Yeah, you kind of managed that epilepsy piece really beautifully.
Thank you. I've got lots of notes.
Excellent.
All right. Anything else from the group? Anyone have any questions or anything? You're very welcome. Good luck to everyone who's going soon. And for my postdocs that were on, I saw a few of you. You're welcome for that bit of Schadenfreude. All right.
You're a champ, Joel. Thanks for sitting in the hot seat. I had the easy job.
It's kind of fun. I do kind of enjoy it, I have to say. It's a fun challenge.
And it's normalizing, right? I think
it is normalizing.
You can miss a few things and still pass and still do a really nice job of demonstrating your competence.
I was a little disappointed that I got the etiology because I want to reinforce like it's getting the brain behavior ties. That's the key. Getting
Absolutely.
the etiology is nice, but that's not the goal. The goal you could fail and get that right.
Absolutely.
So.
Yep, absolutely. All right, you guys got this. You can do this.
Good luck to everyone, and I hope everyone had a more pleasant Tuesday afternoon than I did. I'm just joking, but catch everyone next time. See ya.
Take care.